To give this lecture, we have Dr. Sidartawan from Indonesia. He was born in Amsterdam in 1944, graduated medical doctor 1971, specialist in internal medicine 1984, consultant endocrinologist 1990, and PhD 2004 from the University of Indonesia, Jakarta. He is currently the professor of medicine and endocrinology, University of Indonesia, president of the Indonesian Diabetes Association for 2 terms, and chairman of the Indonesian Endocrine Society for 2 terms. It initiated diabetes education programs and organizations in Indonesia, served 2 terms as executive committee member of the IDF Western Pacific region. Presently, Dr. Sidartawan is leading the Indonesia Diabetes Institute and practicing endocrinology at SS Diabetes Center, Husada Hospital, and Siloam Hospital in Jakarta. Over to you, sir, for this important topic.
Okay. Thank you very much, Mr. Manohar. Again, thank you to Bansi for giving me the opportunity to be part of this very prestigious meeting. Let me share my slides. Okay. I'm to talk about diabetes and cardiovascular disease as a double jeopardy. Although at this moment there's a triple jeopardy with COVID. What is going to talk with the next speaker? The double jeopardy of diabetes and cardiovascular disease. As we all know that the burden of diabetes, according to the IDF Atlas, that the current trends continue. 700 million adults will have diabetes by 2045. The largest increase will take place where economies are moving from low to middle income status. Diabetes greatly increases the risk of cardiovascular disease. Patients with type 2 diabetes have twice the risk of cardiovascular disease compared with the general population. Approximately 75% of people with type 2 diabetes, are at risk of cardiovascular disease. Many people already have macrovascular complications by the time they are diagnosed. And worldwide, 1 person dies every 8 seconds from diabetes and its complications. And 50% of deaths in people with type 2 diabetes are attributable to cardiovascular disease. 85% of deaths from CVD are due to atherosclerotic CVD, including heart attack and stroke. CVD was the cause of death in 2 out of 3 people with type 2 diabetes, more than 65 years of age. On average, at the age of 60 years, life expectancy is reduced by 12 years for a person with type 2 diabetes who experienced a heart attack or stroke. Type 2 diabetes, cardiovascular disease, and kidney disease are all interrelated disorders. As you see that 35% to 45% of diabetes with heart failure have CKD. 20% to 44% of patients with type 2 diabetes have also CKD. 76% of patients with CVD and type 2 diabetes have CKD. There's chronic kidney disease, heart failure, type 2 diabetes, atherosclerotic cardiovascular disease. 32% of patients with CVD have type 2 diabetes. They are all interrelated. The pathophysiology of cardiovascular disease in patients with type 2 diabetes is very complex. Type 2 diabetes shares common risk factors that cardiovascular disease and contributes to vascular damage. Risk factors for type 2 diabetes and cardiovascular disease are physical inactivity, high blood pressure, poor diet, smoking, obesity, dyslipidemia, and metabolic syndrome. And the direct effect of hyperglycemia are arterial stiffness, endothelial dysfunction, oxidative stress, platelet activation, inflammation, metabolic syndrome, metabolic dysfunction. This shares type 2 diabetes and cardiovascular disease. As we know that the cardiologists now, it started with the European Society of Cardiology. They differentiate CV risk categories and recommendations for management of this epidemic according to risk. Very high risk, and moderate risk. The very high risk are patients with diabetes and established cardiovascular disease or other target organ damage, as proteinuria, renal impairment, or 3 or more major risk factors: age, hypertension, dyslipidemia, smoke, and obesity, or early onset of type 1 diabetes of long duration. High risk are patients with diabetes duration more than 10 years without target organ damage, plus any other additional risk factors. And moderate risk are young patients with diabetes duration less than 10 years without other risk factors. Thus, you see here that patients, every patient with diabetes, are at risk. Yeah, the moderate risk, diabetes less than 10 years. What about the ADA? Also, they differentiate also, for treatment of ADA, for statin treatment. Diabetes age 40 for 75 years without CVD, use moderate intensity statin. Diabetes at higher risk, especially those with multiple atherosclerotic cardiovascular disease risk factors, or age 50 to 70 years, it is reasonable to use high-intensity statin therapy. Thus, almost every diabetes patient is recommended to use statin therapy. And even the American College of Cardiology, 2019, for treatment of type 2 diabetes for primary prevention of cardiovascular disease, if the patient has diabetes, A1C 6.5, consistent with type 2 diabetes, you suggest dietary counseling, 150 minutes per week, moderate to vigorous physical activity, and then consideration of metformin. But this is very important. Aggressive treatment of other risk factors. So here you see that it's not only glucocentric. Aggressive treatment of other CVD factors, including lipids. And the AACE, they have the new guidelines also, that diabetes is a high to moderate risk, and the LDL target should be less than 100. These guidelines change the paradigm how to treat diabetes with cardiovascular disease. You said that lifestyle therapy, CVD risk factors algorithm, statin therapy to target desirable LDL levels, the extreme risk level, diabetes and clinical ICPD, the LDL goal is less than 55. And the high risk, diabetes without other risk factors, age less than 40, LDL goal less than 100. This almost every diabetes patient should be treated with statins. But you see here that the cardiologists, they said that the sweet spot cardiovascular risk reduction in diabetes in June 2019. The paradigm for cardiovascular risk reduction has shifted more and more to embrace the concept of treating the patient, not the disease. We are no longer considered internists, cardiologists, or endocrinologists. Instead, we have become true physicians, crossing interdisciplinary lines and blurring boundaries between disease. If we say diabetes, in our mind, we have to think about diabetes, cardiovascular, and renal. That's not only glucocentric. That means we need collaborative approach to clinical management of patients with type 2 diabetes. A team approach to diabetes care can effectively help patients cope with the vast array of diabetes-associated complications. Considerations for optimal collaboration to improve Health outcomes include we have to define the roles of each physician and its responsibilities. There should be effective and established communication between them. The multidisciplinary approach for clinical management, and then by then understanding the patient journey. Multiple complications require multiple approaches. As we know, diabetes, the microvascular complications, the eyes, the kidneys, and the peripheral neuropathy, the peripheral nervous system, the macrovascular complications, brain, cerebral circulation, heart and coronary circulation, peripheral vascular tree. We need ophthalmologists. We need nephrologists, neurologists or podiatrists, neurologists, neurosurgeons, psychiatrists, cardiologists, cardiac surgeons, vascular surgery, orthopedic surgeons. There's profession involved in the care for long-term management, according to the AD standard, endocrinologists, ophthalmologists, podiatrists, orthopedic surgeons, renal and cardiac physicians, mental health practitioners, pharmacists, dietitians, nurses, and pharmacists. All these need to be worked together. And patient-centered care provides optimal outcomes for diabetes care. Early screening and close monitoring can prevent disease progression and complication. Early treatment and treatment intensification. We have to adhere to the guidelines, recommendations to ensure that appropriate treatment is provided and without delay. Patient empowerment. Ongoing diabetes self-management education and support are critical to prevent and reduce long-term complications, and collaborative multidisciplinary team approach and referrals. Routine monitoring and a systemic referral process ensures consistent and ongoing patient support and care. To prevent disease progression and complication, primary care physicians, allied healthcare professionals, specialists, and patients should work together. You see here that diabetes is a multipathology disease. It needs a multifactorial treatment and multidisciplinary approach. These are the steps. First step is anthropometric clinical assessment. Second step is risk assessment and discussion of goals. And the third step is treatment using multifactorial algorithm. Lifestyle therapy algorithm, obesity algorithm, pre-diabetes algorithm, and atherosclerotic cardiovascular disease or get to heart algorithm. Each has this algorithm. The trend is like this. Cardiodiabetology, endocrinologists, and cardiologists working together to improve clinical outcomes. It's already mentioned in 2016 by cardiology. You have to work hand in hand. Cardiodiabetology or diabetocardiology. What do the cardiologists do? In patients with established CVD and known type 2 diabetes, assess glycated hemoglobin and fasting plasma glucose for initial screening, plus OGTT if others are inconclusive. Recommend evidence-based SGLT2 inhibitors or GLP-1 receptor agonists in referral patients with newly diagnosed CVD or at high risk. Initiate evidence-based SGLT2 inhibitors or GLP-1 receptor agonists after hospitalization for CVD events. Collaborate with endocrinologists or primary care practitioners for type 2 diabetes management and risk factor management. And the endocrinologist, his job is assess CVD risk factors, refer to evaluation of CVD if clinical indicated, and initiate evidence-based SGLT2 inhibitors or CRP receptor agonists and referral patients with newly established CVD or high-risk CVD. Collaborate with cardiologists, primary care practitioners, and risk factor management. This, why do we need multidisciplinary care patients? Care pathway. Yeah, nephrology, cardiology, internal medicine, endocrinology. We have to screen for type 2 diabetes. Risk factor optimization. And then evidence-based therapies which influence multi-system health. Building collaboration to create new dimensions in patient care. Time to think beyond A1C, not glucocentricity, safety outcomes and mortality. We have to work together. A shared goal between diabetes care and cardiac care. At my place, I create the diabetes connection care. Cardiologists, diabetologists, endocrinologists, nephrologists work together. Thank you very much. Thank you for listening. Yes.